we met this week here in Park City, Utah, to discuss immunosuppression in liver transplant recipients, and our group specifically discussed immunosuppression in children. And the things that we discussed is that there are potential difference in the pediatric population, that the pediatric patients have taught us a lot through the years about transplantation immunosuppression. A big problem that we have in pediatrics is adherence to treatment, and so how we want to try to minimize and adapt the immunosuppression we give to our children so they can have better long-term outcomes. Pediatric transplantation is very different than adults in the fact that we follow these children for many, many years, and we like to improve their quality of life since they're going to live decades with their organs. So we discuss what is the appropriate induction therapy and the immunosuppression we need to give for the first 2 to 3 months, and then the first 6 months, and then the years to come. So I think in pediatrics we'd like to divide our immunosuppression management early and then on the long-term management. And there are specific things about our pediatric population where we might need to have some variance. Patients that have had malignancies, often children get transplanted for hepatoblastomas or hemangioendotheliomas, and we need to change that. And we also have other diseases like PSC or autoimmune hepatitis that may need to have a different adjustment. I think the conference was a great way to get together centers from different parts of the world. And before the conference, we were able to connect with many of our colleagues around the globe to try to create a registry of pediatric liver transplant programs so we can all learn from each other and then work together to improve the long-term care of our children.